next few minutes, I'll take you through a few of the wet AMD patterns. So basically, why Octa for delineating these? It enables us to see it very distinctly, and the patterns are well delineated compared to FFA and ICG, and the morphological classification is possible. What are the implications? I hope to learn that from the masters. And when we see all these beautiful patterns, I think it's nice to exercise our imagination also, because we have wonderful names, and I'll take you through some of them. Subtypes, type 1, we know, type 2 and type 3, the RAP, and as well as PCV is what I'll be covering today. Especially useful for type 1 because these are under the RP and they're seen well with Octa and not with the other imaging modalities. So here we start with the beautiful patterns. The first one is the Medusa Head. The main thing about this is that you can see the vessels radiate from the center of the lesion to a center stalk. The second being the C-fan, where you can see the vessels radiating up to a particular side. There's an indistinct pattern with vascular trees, and these are the ones which are supposed to be the more mature ones, the prune tree and the indistinct network. So these are the beautiful morphologies. You can see the Medusa Head first, the glomerulus, and the lacy wheel pattern, and these have been beautifully described by Dr. Lombroso. So there was an article by Dr. Koskas, which I think Dr. Anand Rajendran also spoke about earlier today. And he has said that pattern 1 or active CNV is present if we have at least 3 features of the 5 below. This is a well-defined pattern, lacy or C-fan shaped, branching dense capillary network, presence of anastomoses or loops, vessel terminus in front of a peripheral arcade, and a perilesional hypointense halo. And it's supposed to be pattern 2 or quiescent if less than 3 of the above features are present in a lesion. So this is one of the lesions. You can see first you look for the morphology, the capillary density, look for the branching, look for loops, and see if the vessels, are they thin or thick. And of course, Dr. Spade has described beautifully about how the repeat relapses cause arterialization, where you get thicker vessels as you keep on going on with the treatment. So this was the article by Koskas, which I've already described. And these were some of the patterns we found in our collection. You can see the Medusa Head, and this looks active, a pattern 1. And please keep using your imagination. This is a C-fan. This is a glomerulus, which we used to learn in medicine, the glomerular pattern. And the high flow tuft, which is characteristically seen in RAP lesions. Long filamentous is a pattern 2. Here you can see it looks quite bare and maybe a relatively inactive lesion. So in type 1 CNVM, of course, like I mentioned, you can see the occult CNV in microvascular detail, and Medusa Head, of course, or the C-fan are the common patterns seen. So these are some of the cases where you can see the type 1 CNVM. And the type 2, if we move on to, also has this Medusa Head or the glomerular shape, which is common. And of course, the glomerulus is compared to the kidney glomeruli, and it harbors globular structures of entwined vessels which are separated by the hypodense spaces. And you can see here the glomerular pattern in the type 2 CNVM, which is very well delineated in this section. This was another type 2 CNVM, and we can maybe imagine it to be a bit glomerular. Type 3 was covered beautifully by Dr. Parveen Sen, and we can see in this, Octa lets us see these vessels which are interlinking very well on Octa. Sorry. And there's another case, you can see the aneurysm-like dilatation, and you can see when you cut through the scan, you can exactly see where this invasion is taking place and where the RP cleft is coming up. So one of our postgraduates studied this, and they found that out of the total 60 patients studied, the Medusa Head was the most common, followed by a C-fan pattern. And interestingly, when you did a sub-analysis of this, in the type 1, the C-fan was more common, type 2 Medusa Head, and the type 3, the high flow tuft, was found to be the most common pattern. So I think we've heard a lot of optimism and pessimism. So what are the disadvantages of OCTA in PCV? There's a very variable flow pattern in polyps, high and low flow, both of which are not well visualized. Segmentation and projection artifacts due to the large PD present, and the useful will be limited by a lot of edema and hemorrhages. So now let's move and let's be a little optimistic and see what we got. So here you can see a nice BVN, and the polyps at the cluster at the edge of the BVN in this patient with a large PED. And here, like we have described earlier also, the BVN is seen better with the Octa, but you can see the ICG beautifully picking up the polyps. Another patient of PEHCR, peripheral exudative hemorrhagic chorioretinopathy, one of my favorite things I'm trying to study now. So you can see this is the ICG, and here's the ICG compared to the Octa. And you can actually see the polyps here, and you can see the flow on this with the swept source OCT. This is another case with a peripapillary CNVM, and you can see the BVN, and it's terminating into these polyps. And you can see the polyps nicely on the ICG, and you can kind of, as I said in the first slide, imagine them nicely at the end of this. So this is the case. This is, again, you can see the blue arrow showing the BVN tangling, and the yellow arrow showing the polyps at the end of the BVN. And this patient underwent therapy with, I think, Eylea with focal laser because it was extra. And you can see how nicely the flow and the huge PED has come down. This is pre-therapy, and this is post-therapy on the right. So to conclude, we see beautiful patterns on Octa of wet AMD. Practical utility, I'm not very sure. It's open to discussion. Dash of imagination and an open mind go a long way in seeing these lesions. Thank you very much.